Good morning, and thank you very much. It's really my honor to be here as a hepatologist to talk in an AIDS symposium. This is my first AIDS symposium in my life, and it's my first time to receive so many tiny little gifts in a symposium. So I will set the stage for the talk for other speakers for today, and I'll focus on the global burden of hepatitis infection. I'll first touch on C, and then I'll go to B. So hepatitis C is a very common infection all over the world. Most people think that HCV is a Western disease. But if you look at the world epidemiology, you realize that around 3/4 of the HCV population actually reside in the Asia-Pacific area. And the slide just actually shows that the prevalence of HCV infection in the blue circle in some specific Asia-Pacific countries. Overall, there are 130 to 170 million people infected by this infection. So this is something really big. So when we move a little bit to the Asia-Pacific area, the prevalence in different countries varies. The highest prevalence country is Mongolia, with 10.7% prevalence, followed by Pakistan, 5.9%, and Cambodia, 4.1%. So for all other Asia-Pacific countries, the prevalence is somewhere around 2%. So in Hong Kong, it's actually quite low. It's only 0.5%. But we need to be very cautious when we interpret prevalence data because HCV mainly affects certain at-risk groups. So how the survey is done will definitely affect the percentage reported. HCV is important because it causes a chronic infection. It can increase the risk of cirrhosis. It increases the risk of cancer. And the risk of cirrhosis increases with the duration of infection. So it is estimated that HCV causes about 27% of cirrhosis and 25% of hepatocellular carcinoma all over the world. In Southeast Asia, about 17 of them are unaware of HCV until they have the symptoms of cirrhosis and cancer. So this is a very silent disease, and it has a long-term liver-related sequelae. So this is a natural history of HCV infection. After acute exposure, about 15 of the people, they are quite fortunate, they can resolve by themselves. But 85% of the infected individuals will develop chronic infection. This is a very indolent and silent infection with usually very mild ALT elevation, rarely have very significant flares, and cirrhosis will develop in about 20% of patients. So once cirrhosis is developed, then this patient may develop into an end-stage liver disease, and also there will be increased risk of liver cancer at about 1 to 4% per year. And HCV is currently one of the very important causes of liver transplant in the Western population. We know alcohol use, obesity, HIV, HBV co-infection can accelerate the progression of HCV infection. So this graph shows the pattern of age-specific prevalence of HCV and also the change of prevalence of HCV infection in a few selected countries. And we can see that the change of preference actually differ in different countries. Just take Egypt as an example. You can see the age-related preference actually goes up, with older individuals more affected, and the incidence of infection also goes up. In contrast, Japan, which is the purple line, that although the age-related preference goes up, but the incidence of HCV-related advanced disease actually goes down because it is related to the mode of infection, whether the infection is continuous and whether the disease is treated. Like in Japan, it's mainly a post-war infection, and there are not many new infections in the current past 2-3 decades. So you can see that the incidence of age-related advanced disease actually drop. Australia, USA has a modest increase in the past decades. For HCC-related HCV, Japan is most badly hit. About 79% of HCC in Japan are because of HCV infection. Here in Australia and New Zealand, it's somewhere around 30-40%, and in all other parts of Asia, is somewhere around 10 to 20%, with a very low preference in Hong Kong, Philippines, and Malaysia, and it is mainly because of the importance of HBV infection. Majority of HCC over those regions are related to hepatitis B instead of hepatitis C virus infection. Well, we have a lot of new treatment, and I'm sure our next speaker will address on that, but there are a lot of barriers to HCV therapy. So this is a global survey on also patients, doctors, government, and also payer on what are the barriers to treatment in HCV. And if we focus on Asia Pacific region, the three key barriers are: number one, medication expense; number two, the fear of side effects, because this survey is done mainly in era with interferon. We are not talking about interferon-free treatment for this survey. And also treatment duration, which usually takes about a year for a traditional PEG interferon ribavirin dual therapy. So when we talk about Hep C treatment, of course we have a lot of new drugs. We know that scientifically HCV is much better cured, but the problem is the access. Well, if we look at the survey data of America, Japan, and also another data presented by the Chinese official, HCV preference is very high, but only a small percentage is being diagnosed. 38% in America, 60% in Japan, and very, very low percentage in China. But even among those who are diagnosed, the percentage who are treated is even lower, with multiple reasons, and some of those are explained in the last slide. So I move away from Hep C into Hep B. So worldwide preference of Hep B is high, mainly focused in Asia Pacific region and Africa, with a preference of more than 7%. Australia New Zealand belongs to a lower preference region, and also America, Europe, Western Europe also belongs to a lower preference region. So overall, there are more than 350 million HBV carrier in the world. In a 2010 global burden of disease study, HBV infection was the 10th leading cause of death, accounting for 786,000 deaths per year. About half of the total liver cancer mortality in 2010 was attributed to HBV infection. From 1990 to 2010, the worldwide mortality associated with liver cancer increased by 62%, and fat associated cirrhosis also increased by 29%. When we focus in Asia, actually again, 3/4 of HBV carrier are in Asia-Pacific countries. So there are about 260 million HBV infected people in Asia, and 160 million are residing in the Western Pacific region. So the Western Pacific region, we have 50% of all HBV patients in the world, 60% of HCC in the world, and 360,000 people died of HBV-related liver disease every year. So this is a report from different countries looking at the importance of HCC as a cause of liver cancer. So in most Asian Pacific countries, particularly in Southeast Asia, HBV accounts for about 80% of liver cancer. A lower preference in India and Philippines, and even lower in Singapore. Some of it is because of hepatitis C. Some of them are because of the increasing incidence of HCC related to fatty liver disease. Universal vaccination is a breakthrough in the mid-80s. It is first launched in Taiwan. Right now, 180 countries in the world has this program, so it's around 3% of countries in the world. The prevalence in ASHG positivity in Taiwan has dropped tremendously after 25 years of vaccination. If you look at the recent publication by the Taiwanese group, the prevalence of HBsAg was about 10% among those who are aged 28 to 29. So these are the group that are older than the vaccination era. But when we look down to those who are younger than age of 25, the prevalence of HBsAg was as low as 0.9%. Even for those who are per readed years of launching the vaccine, the prevalence was about 6%. So definitely HBV vaccination has already reduced the prevalence of HBV infection. But we need a little bit of time to see the impact of HBV vaccine on liver cirrhosis development and liver cancer development, because all these takes 20, 30 years to develop. If we look at the childhood HCC, the Taiwanese has a very good data showing that it has decreased after launching of HBV infection. The annual incidence of childhood HCC dropped from 0.7% in the early 80s to 0.19% in year 2007. So this is a significant reduction in childhood cancer, and we do need more time to see the benefits in adult cancer. Well, this is not the end of the story, because the problem is we need a complete vaccine coverage. That is, we need a 3-dose regimen vaccine. And also for babies born from carrier mothers, we also need a dose of passive HBV vaccine. So when we look at the 3-dose HBV coverage in infants in 2010, the global coverage was only 75%. And the worst is the blue line. And the blue line is in actually Southeast Asia. So in Southeast Asia, the coverage 3-dose was only 50% in the Asian region. So this is a big problem, and it may be related to accessibility of the vaccine, particularly in people living in a village, or another thing is education, because the people have to go back to the hospital clinics to receive the second and third dose of vaccine. And there's a very recent report in Taiwan, I think it's just published in Hepatology this month or the month before, showing that incomplete vaccination is the most important cause of HCC, fulminant hepatic failure, and also chronic disease among those who have received vaccines in the past 20 years in Taiwan. But we still have a lot of people who are older than age of 20 to 25, they need treatment. And the treatment pattern is very affected by the reimbursement policy by the government. So in fortunate countries like here, like in a high reimbursement area, then entecavir, tenofovir are the most commonly used treatment. The problem is mainly high cost to the government, but it's good to the patient. On the other hand, for low reimbursement areas, like in Thailand, Indonesia, Philippines, Vietnam, lamivudine is still the most commonly used drug. And we know that there are lots of drug resistance, and it has created still big problem in the HBV community. And there are some countries sitting in between, like in Hong Kong, Taiwan, Korea, and China, that we have a partial reimbursement system. And the drug use is according to the reimbursement policy. If you're not for everyone, say in Taiwan, it's only for 3 years. In Hong Kong, Korea, China, with very strict reimbursement policy, and some patients who may fall under the treatment guidelines, but not in the reimbursement guidelines. So they have to pay for their own drugs, and this also affects the coverage. This is one example in China, that when we used a lot of lamivudine and also drugs with low genetic barrier to resistance, we have a big problem of resistance. We're not talking about of LAM resistance, because a lot of these patients are being treated by sequential therapy of different drugs. So you can see a whole lot of interesting resistant mutations, and this graph actually shows the entecavir resistant mutation among 794 patients receiving this sequential or combination treatment, chasing after the resistant strain. So this is definitely not the preferred practice. So to sum up my talk, we see there's a huge global burden of HBV and HCV infection in the world. It is a major cause of HCC and mortality. In Hep C, we know with great advances in antiviral therapy, and our second speaker will elucidate more on that. But the challenge is actually in accessibility and affordability of the vaccine. In Hep B, vaccination has significantly reduced the burden in the younger generation. We still see a lot in the adult population, but the challenges is in accessibility of vaccine and also in antiviral therapy in existing patients. Thank you very much.